Good morning, everyone. Welcome to Pediatric Grand Rounds Day. If you're anywhere near the Temple Complex, please join us in person. We have a big breakfast. I'm not just saying that to get you here. We do actually have breakfast, so please join us. Today's speaker is Dr. Cynthia Morrow, MD, MPH. She's the Health Director for the Roanoke City and Alleghany Health Districts. She also serves as Domain Director for Health System Science and Interprofessional Practice at VTC-SOM. Prior to moving to Roanoke in 2017, she serves as Commissioner of Health for Onondaga County, New York, and Learner Chair for Public Health Promotion at the Maxwell School, Syracuse University. She has co-authored, co-edited 5 public health textbooks. She earned her bachelor's degree from Swarthmore College and a combined MD and PH from Tufts University School of Medicine in Boston, Massachusetts. Please join me in welcome Dr. Cynthia Morrow.
I thought you were going to just introduce me as your friend. So I don't know if any of you were here. I was here a couple of years ago, and it was the same title. I promise you it's not the same presentation, but the overall theme is just how we can work together, the public health and the healthcare delivery system. And of course, in this regard, it's about how do we protect the health of children. So we're going to review the leading causes of health. I just looked at that. Death, not health. You know how you can look at your slides 1,000 times and not see something, and then it's on a big screen and it's like, holy smokeroons, how did I miss that? Leading causes of death. So you're going to see it twice because it's the concluding slide as well. So we're going to focus on that, knowing that as pediatricians, hopefully you're not dealing with death ever, but I think that there's some misinformation that I have contributed to in terms of leading causes of death in children. So I wanted to kind of go over that a little bit. And I can't not have a captive audience and talk about some of the hot topics in public health. So the focus is going to be on leading causes of death in children, but we're going to look at what's going on with syphilis and hepatitis C and how that impacts the pediatric population as well. So how are we going to meet these objectives? The first thing that we're going to do, what are the objectives? I hope that you can restate what the leading causes of death are, and have an open discussion about what that means. Describe some of the hot topics, again, have an open discussion, and then talk through some of the services that we, as the public health agency, have to help you with your patients. And so we were just talking about this. I will stay within the hour, but it's probably not going to be 40 minutes of didactic and then just questions. At any time if you have questions, please stop me. It feels much more organic. That goes for the folks online as well. It just makes it feel much more comfortable. But I always start with this, so those of you who have seen me in front of the classroom, feel free to chime in, but just what is public health? So before we go into what the public health system does, what is public health? We just talked about that, so you get a pass. I'm comfortable with silence, so.
It really is.
Health for the greater good of the population. Absolutely, so we look at the entire population rather than the individual patient. Other ideas of what constitutes public health? Yeah.
How systems and policies affect our health as opposed to just the medical health.
So how do systems and policies impact health outside of the healthcare delivery system? I mean, of course, it includes the healthcare delivery system, but what's happening outside and how? And absolutely, that's sort of one of the root causes. So there are different definitions of public health. The World Health Organization talks about the organized effort of society to improve the health of the entire population, the greater good. National Academies of Medicine says what we collectively do as a society to assure the conditions in which people can be healthy. And so that's what I want to focus on is what can we as the public health system and from the healthcare delivery system do to assure the conditions in which people can be healthy. So we look at the socioecologic model. That's, I think probably most people are really familiar with the socioecologic model, but all individual health outcomes other than genetic, and we're going to look at leading causes of death, individual outcomes are impacted by relationships. So as healthcare providers, the best way for us to influence individuals' decisions is to ensure that we are firmly in that interpersonal sphere of relationships and have built trust in order to influence behavior. We know that parents, like if we think about the Back to Sleep campaign, what grandma and mom taught new parents was far more influential than what physicians did at the time, right? We had a huge challenge of trying to change the culture around back to sleep because, well, grandma told me that, blah, blah, blah. So as long as we can insert ourselves into having equal value to grandma, we can make a change. But community influences and community resources in turn influence relationships and individuals, and of course, policy is frequently at the level of society. And so from a public health and a healthcare delivery system, it's really important for us to remember that individuals are all influenced by these other spheres. And that's what we're going to talk a little bit about with respect to what the health department does. That's going to be at the community level as well as the society level. At the end of the day, in order for us to effectively improve health, we need to look at social and structural determinants of health, and I know that Vivi is all over that. We need to look at the public health programs and systems, and we need to look at healthcare delivery. All of these influence our ability to improve health. But in order to understand that, we need to understand the data behind all of this. So medical students have heard me say this. It's critically important. And when we're talking about leading causes of death, really learning how to be critical thinkers around the data is important. So data leads to information, information leads to knowledge, knowledge leads to wisdom and how we can best care for the patients in front of us, and for me, for our community. So, we're going to now dive into some data. Mortality data. How do physicians impact mortality data? Where do mortality data come from?
So like death certificates.
Death certificates. Who fills out death certificates?
The physician.
Physicians. How many of you have filled out a death certificate without necessarily knowing exactly what happened? Really?
But I have encountered lots of cases where it was clear that the physician filled out the form and didn't know exactly what happened.
Okay, so because sometimes it's really hard. So if you have a situation where you don't know exactly what happened, let's say it's a SIDS death, right? What are you going to do? Where does that death get investigated? Are you going to fill out that death certificate? Where does it go? Medical examiner's office, right? So for children, death certificate data are actually usually really high quality data because for the most part, if you don't know, you're going to send it to the MEO. Right, and the MEO has a legal obligation to investigate, and they're going to do a medical legal investigation. So we're going to talk about SIDS in just a few minutes. But at the end of the day, if you have a death certificate, you are obligated to look at the immediate cause of death, the underlying, and there might be two, the intermediate cause of death, the underlying cause of death, and contributing factors. And again, this is probably where it's a little bit different. And so I probably should just ask the question, how many of you have had to fill out death certificates? So not everybody has had to do that yet. It's not the most fun job in the world, but it's critically important and it does inform all of our data. It isn't as problematic in children as it is in adults. In adults in Virginia, if an older adult dies it's up to the physician to figure out what that cause is, even if they don't know. And the medical examiner's office is not situated, it's not adequately staffed for them to investigate every death. So physicians for adults are in the precarious position in Virginia of frequently having to fill out a death certificate without knowing exactly what happened. And they just have to do their best guess. And it is a legal obligation. There's no choice. You can argue that I don't know, but you're still going to have to fill out the death certificate. So that's a bit of a problem. Children, anybody under the children, it's going to go to the MEO regardless. So the reason that I'm harping on this is how we classify deaths. So physicians at the end of the day are ultimately responsible for determining the cause of death and all of the underlying causes of death. Why does that matter? Well, hopefully most of your life is about preventing children from dying. Obviously, that's the worst outcome. We do need to understand what is contributing to childhood deaths. So what is the leading cause of death in children?
Prematurity.
Motor vehicle accidents or accidents.
So we're getting all sorts of answers. And that's the right answer. It depends, right? It depends on the age. So I heard firearms, I heard prematurity, I heard accidents. All three of those things are true. Well, prematurity is
Genetic, it's under genetic.
genetic anomalies are so the most important thing is that we break it down by age. And this is where I've been misleading in some conversations that I've had lately. And so in preparing this, I'm like, wow, I really need to be better about this. So the reality is it depends. It depends on the age of the child. And overwhelmingly, where does the vast majority of our childhood death happen? What age group? Overwhelmingly? In the under 1 population. Right, so if we look at infant mortality rates in 2022, the infant mortality rate was 5.6 per 1,000, which is 560 per 100,000. All of the rest of these are in 28 per 100,000, up to 89 per 100,000 in the 10 to 19-year-old. And so the challenge also is that it's in a lot of places, or 10 to 15-year-olds. I just said that wrong. What they also do is they'll combine age. So these data, the way that injury data are presented, leading causes of death data are presented, is by 5-year increments until you get to 15, and then it's 10-year increments after that. But for pediatrics, we typically talk about less than 18, right? And so firearm injury, we're going to spend a lot of time talking about firearm injuries and firearm deaths. But if we look overall, the majority of children are dying in the under 1 age group, and the number 1 cause of infant mortality is congenital anomalies, followed by extreme prematurity or low, it's going to end up being low birth weight, right? SIDS, so if we look at infant mortality, what I frequently hear is that SIDS is the most common cause of death. And what do you think, when people are talking about that, they're typically talking about preventable causes of death, right? And one of the things that has happened in my lifetime as a public health professional is that we have dramatically changed the way that we do death scene investigations of SIDS. And that's what made me go back to the medical examiner's office. So we used to say that SIDS was any death that happened while a baby was sleeping, right? But what we know now is that overwhelmingly sudden, unexpected death in infancy, so SUDI or infant death, if we're SUID, it's done both ways, is in unsafe sleep environments. Like overwhelmingly, We were able to do, this was in New York, a really deep dive into our infant mortality. And we found that of the cases that were initially identified as SIDS, over a 10-year period, about 80% of them were misclassified. It was suffocation, it was co-sleeping, it was something about an unsafe sleep environment, overlaying, etc. And so we haven't quite figured out at the national level how to differentiate SUDI or SUID and SIDS. So a lot of SIDS deaths at the national level are actually unsafe sleep deaths, just so that you guys know that background. And we're going to come back to that from a public health perspective at the very end. Unintentional injury deaths from ages 1 to 4, drownings, followed by motor vehicle accidents, 5 to 9, motor vehicle accidents followed by drowning, 15 to 24, and I know that this crosses into the adult population, but this is the way that these data are captured, motor vehicle accidents followed by poisonings. What do you think? So these are all accidental. I'm going to go back, sorry. For all of the other age groups in children, it's unintentional injuries. All of the other age groups. Now, we're going to come back to firearms in a little bit, but that's why I broke it down by these. Do you know poisoning starts showing up in 10 to 14-year-olds? And then poisonings really jumps in 15 to 24-year-olds. Why? What is considered a poisoning?
Well, substance abuse.
Substance abuse, and that's not intuitive. Like a lot of people think of poisoning in children, oh, a kid got into the medicine cabinet, right? We know by looking at the unintentional injury death data that it's actually substance use disorder. It's not poisoning in the classic sense that many of us think about poisoning. And again, it gets back to understanding where data come from and how we label data. Does that make sense? All right. But wait, what about firearms? Yeah.
Would accidentally, not accidentally, deliberately, attempted suicide.
So the way that deaths are qualified, that there are 4 categories of death. There is natural cause. So a child who's born with a congenital anomaly is not expected to survive. That's going to be a natural death. There's homicide. Obviously, if an 18-year-old points a gun and shoots at a 16-year-old, that's going to be, well, intentionally shoots at a 16-year-old, that's going to be homicide. Suicide, obviously self-harm, self-intention, and then accident. So those are the broadest categories of the way we classify deaths. And in children, a lot, it's the accidental deaths, so that's when they break it down into the subcategories of accidental. And poisonings are considered accidental unless we have evidence in the medical legal in the investigation that it was intentional, in which case it will automatically be put into the suicide category. So thank you for asking that question, because I should have clarified that. So if we think about this and we think about firearms now, firearms are going to, by definition, there is no such thing as a natural death associated with firearms. Not going to happen. So it's by definition going to fall into homicide, suicide, or accidental. And that's where it gets a little bit confusing. So the general rule, when we talk about leading causes of death, we're talking about immediate cause of death. And the challenge, I'm going back the wrong way, the challenge with firearms is what?
So if you've broken up the firearm deaths into different categories, then you're not really looking at the overall numbers of people who have died from gun-related injuries.
And it's gonna cross all of those categories,
So if you're a
right?
gun control advocate, then you don't have the data to support gun control.
It makes it much harder, and there's a whole level of complexity behind research on firearms deaths and injuries. There's a tremendous amount of complexity, including legislation in the past that prohibited federal agencies from doing research on gun outcomes, suicide, homicide. So it's really complex. We haven't had good data behind it. But if we're looking at, if we can pull those data, instead of looking at them like this, we can start looking at the actual cause. Some people would not like it that I say this, which are the guns, right? And so that's where all of this information, right? This just hit the news big time. Childhood's greatest data, kids and guns. Guns are the leading cause of death for children. Firearms overtook accidents is the leading cause of death for children. Big, huge caveat, children above the age of 1. Right? Because children below the age of 1 are still overwhelmingly outnumbered in terms of deaths, children above the age of 1. So I'm not discounting it at all, but we have to be careful about our data. And generally speaking, the firearms data are going to be looking at children between the ages of 1 and 18, 17, through the 18th birthday. So it's just a little bit muddy. Right? And it's really important for us as we give information to make sure that we're clear on the data so that we're not confounding the story itself. So clearly, if we're thinking about preventable causes of death, we must look at firearms. We must. It is an obligation because they're entirely preventable. 100% of them are preventable. And so then I'm going to just spend a little bit of time, now that hopefully you have a good understanding of the data, right? Overall, infant mortality still far exceeds mortality over the age of 1. Accidental deaths far exceed the other causes of death in children. But we're not counting the different, if we're counting the actual mechanism behind it, which is firearms, we're combining accidental, suicide, and homicide. Does that make sense? You guys following? Because even, so you're going to see that chart that says accidental is still the leading cause of death. But combining suicide and homicide for firearms is an important, different way of looking at those data. Does that help? So firearms were involved in more childhood deaths, remember, above the age of 1, in 2020 and 2021 than any other cause. And so this is where we start looking at, okay, firearms are killing more children than motor vehicle accidents, cancer, suffocation, congenital anomalies, poisonings, and drownings, above the age of 1. And if we look at it, clearly, not shockingly, we are the massive outlier in the world, where in most countries, it's either going to be motor vehicle accidents or cancer as the leading cause of death in children between the ages of 1. And this one's 19. Everywhere you look, it's going to be different numbers. Just pay attention to the numbers, pay attention to the details so that you know what you're looking at. And then if we look at the United States, sorry, I wasn't it's a little bit messy, but there are very different rates of firearm mortality depending on what state you live in. If you are interested, this is from Kaiser Family Foundation, and it actually looks at all of these data by policies as well. So it gets back to the definition of public health, looking at policies. So you can look at these data by the state's gun control policies, and it's not a surprising outcome. But anyway, that's, if you're interested, the link is in the slides. This is something that I think is really important. We talk about accidental injuries, and I'm going to show you some data about accidental injuries in a few minutes, but the reality is that the nature of gun violence among children is changing. Accidental deaths have gone up a little bit, but there's still a tiny, 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 tiny fraction of what's happening. Unfortunately, both firearm suicide and firearm homicide are significantly increasing. For those of you who might be interested, and I do not expect you to see this, this is just for the unintentional injury deaths, which is that smallest number on there. For the unintentional injury deaths, there is now a lot more research around what's happening. And you can, there's a way of looking at who is the perpetrator in an accident, so if that's not quite the right word, and who is impacted. And boys are overwhelmingly the victims of, this is unintentional, right? So these are the accidental gun deaths. Boys are overwhelmingly disproportionately impacted. In younger age groups, it's siblings who have access to a gun who are mistakenly shooting their siblings. As it gets to older children, and this is just what I wanted to, because it's different when you're counseling your families about firearms, counseling about a firearms possession in a home of a 2-year-old is very, very different from that in a child, in an older child. So in children, in young children, it's the sibling. In older children, it's a friend. So that's a different counseling for you as pediatric providers to talk to families about, do you own a gun? Well, for adults. For older children, do you know if there are any guns in the friends of your children's friends' houses? Right, that's a very different conversation than do you own a gun. But and I know you guys have to counsel about 1,000 billion things, but knowing that firearms are such an important cause of preventable deaths in children, I think that it is critical that all pediatricians feel very comfortable in having the discussion about, does your child have access to firearms, or do their friends as they get older? Does that make sense? So that we do have a lot more data today than we used to have. So with that, I'm going to take a pause. Are there any questions about leading causes of death? I know it's a little bit muddy because I've thrown out, well, guess what? Here's this slide that says that overwhelmingly it's accidents, but yet firearms are the leading cause of death in children above the age of 1 because we're combining the homicide, suicide, and accidentals. Does that make sense? Any questions about that?
I have a question. In a couple of recent, really high-profile cases involving school shootings, the parents have been charged. Most recently, the one I think was in Georgia, the father was charged with second-degree murder, and then there was one before that. I think maybe both parents were charged. But just if you could just comment on that, and if you feel like that would be an effective way to mitigate the problem to some extent.
You know, I don't know. I don't think that it's just so new, this approach. What I can say, it's not surprising, the argument, the controversy, and I know that's a little bit derogatory when I put it in air quotes, but the controversy about public health and firearms being a public health, that public health should stay in their own swim lane, that doctors should stay in their own swim lane. Like, I don't know if you heard there was this whole thing, this whole Twitter X thing, about stay in your own lane after one of the mass shootings, and AAP came out with a really loud, clear statement. Like, this is our lane. I think children are dying. It is an absolute public, to think that a leading preventable cause of lower life expectancy is not a public health issue is insane. Like that's, of course it's a public health issue. And of course it's a doctor issue, right? Of course this is your swim lane. So just to put it out there, I'm not shy about this. This is a public health threat. In terms of how we mitigate the public health threat, clearly laws about safe firearm storage, so I don't know if you guys are familiar with, as medical students, we've done a case on this, about many states have tried to pass laws to prohibit physicians from talking to families about firearms. They haven't been successful, but they're still ongoing, which is crazy. Like, why would physicians be prevented from talking about something that kills children? Like, I'm nutsy. So, not that I have strong opinions about this at all. There are so many layered approaches. It's hard to get into that. The question that you're asking about, is it possible that there will have an overall chilling effect as parents are held accountable for children's behavior is yet to be determined. I will say I have mixed feelings about this. I think that there are clear situations like where a parent gives a child a gun and knows that child has been investigated. I mean, this is media. I have no inside knowledge about this at all. And we know that media doesn't necessarily tell us the whole truth. But to me, that seems like it's reasonable. That's a reasonable thing to hold a parent accountable for. But you guys are all pediatricians. How many adolescents make real terrible decisions that have nothing to do with the parenting? Right? So I think that we need to be really, really careful about holding parents accountable for adolescents' behavior. Did any of you read, oh my gosh, I'm blanking on it. Yes, Your Child is Crazy. One of my children was a very, very challenging adolescent. And it's this beautiful book that the title, of course, is stigmatizing, and I don't even think it's out in public, but it talks about, it starts with physiology, it starts with what's happening in an adolescent's brain, and how we, as parents, support our children through adolescence. And the bottom line is, I mean, you guys know this. I feel like I'm a goose standing here and talking about this right now because you know this infinitely better than I do. But I just think that we have to be really cautious about holding parents accountable for adolescents' behavior. I don't know, what do you guys think? I'm seeing some really vigorous nodding. And in extreme situations, they must be held accountable.
Well, as a parent of a challenging child, I can't control what my child does, but I can control the environment that my child is living in. So, you know.
Such a beautiful way of wording it. Yeah. That's such a beautiful way of wording it. And if you've done everything you can to control that environment, it doesn't make sense to hold you accountable. I don't know. But I would be totally happy if you guys want to disagree or talk about it more. Does that help at all? And the bottom line is we have to see what happens. We'll see. So anything else that you guys want to talk about?
Question.
Yeah.
Does Virginia's data match what's showing up on the national level? I am not aware that we have this level of granularity for Virginia. We now have a firearms dashboard. It's a brand new dashboard, but it doesn't get down to this level of granularity. And I'll look at the dashboard again, and if I find anything, I'll let you know.
So the slide that you showed had the state violence gun, right, that one. Right, so what specifically is it that's different about Louisiana laws compared to New York laws? Do you know?
I don't, what I can say is it's complex.
So there's sort of gun purchase related laws, but then are there laws related to gun ownership that are different between states?
Yes. So that there are so many different levels of gun control policy. I would be misguiding you if I pretended to know the nuances of the different policies. As a general rule, the Kaiser Family Foundation report gets into a lot more detail, but there are so many different levels of policy interventions, from registering to ownership to storage to reporting and research. I mean, there's a lot of complexity. The overall gist of the Kaiser Family Foundation report, which again is not at all surprising, is a strong correlation between how many policy or how much gun control legislation is in place and the mortality rates. I will tell you, or will say that kind of like immunization policy, the policy may not be as important as the enforcement of the policy. Because there are policies in place that aren't being enforced for gun legislation. So that's kind of a really wussy answer. But the Kaiser Family Foundation report is really phenomenal. It gets into a lot of detail. Yes?
You don't mind going into another public health issue?
Yeah.
What are your thoughts about COVID immunization in children at this time as it relates to the strains that are out there and the level of disease that is out there? And do you have different opinions than the CDC's party line?
Oh, you're gonna put me I was, at the beginning of the COVID pandemic, you would not find a more strident supporter of COVID vaccine. And there was so much that we didn't know, right? We didn't know. So I get really frustrated, honestly, when people now quarterback Monday night, I'm so bad with analogies, but go back and look at what we did. We did the best we could with the information that we had available to us. And what we knew was a 1% mortality rate, 1 to 3%, depending on the data, for a new disease. 1% mortality rate for a population is jaw-dropping. Like there's nothing like that, right? It's an entirely different situation today. There isn't good evidence that the circulating strains are less virulent, but it's complicated by the extent to which there's natural and vaccine-mediated immunity, right? Because we just don't have a naive population anywhere. Even if you don't think that you've gotten it, even if you've never tested positive, you probably got it at some point. So can I, in good conscience, say this is critical for everybody? No, I can't. Do I think we are still seeing hospitalizations in children under the age of 1? You guys are seeing it, right? Do I think that we should encourage it for everybody? Yes. And the reason is, and this is a really old study, but there was a really well done, albeit old study in Japan, that if you vaccinate children, mortality rates in long-term care facilities decreases significantly. So if we think about it as the risk of vaccinating children is, I can't say 0 because nothing is 0, but it's pretty darn close. If we can vaccinate not to protect the child, because as long as the child is immunocompetent and healthy, they're probably going to be just fine if they get COVID, right? But from a societal pressure perspective, pressure meaning not just pressure on society, if we really want to protect those people who are most vulnerable, which is our over 65-year-old, really over 75-year-old population, vaccinating children is one of the strategies to protect our older adults. No.
My next question.
It's not a great argument. So there's some evidence that the COVID messaging, this is going to get political. There's some messaging that the COVID, so I was really strident, again, using that word a second time, about I'm getting my vaccine because my 86-year-old mother lives with me. That message of I'm doing it for other people actually had a negative impact on certain demographics. I know, but that there's a really interesting study that shows that that actually deterred, that messaging of I'm doing it for you was actually a deterrent in certain populations. I know, it's shock. I'm seeing you guys. I know it's such a sad statement about society, and it's true. You know, I mean, all studies like this are flawed studies. They're not perfect studies, but I looked at it and I was just like, oh. And I can't change that messaging. But that's the end of the day. Do I think that you as pediatricians should continue to encourage it, even though it's probably not going to significantly benefit the child in front of you? Yeah.
Well, there's a difference between encouraging it and really pushing it hard, you know, and that's where
I would say if you think about it like pertussis, right? So we were all in a pertussis, continuing sort of slow running pertussis outbreak. I should have put that on there. And I do want to get to some of the hot topics, but this is I love this conversation. If we think about it about pertussis, right? Our messaging is cocooning. We want to protect our people who are most vulnerable by making sure that the people around that person are vaccinated. I feel that's how we should consider messaging COVID. But that is an opinion. That is not official CDC.
I appreciate you giving your opinion.
Thank you. All right. So I just want to go into hot topics that might impact you. So the syphilis epidemic, has everybody heard about the insanity of the syphilis epidemic that we have going on right now? Yeah, it's nuts. Our cases have gone up dramatically. So in the United States, syphilis rose by 80% between 2018 and 2019. To put this in perspective, congenital syphilis, we had, I think, around 1,800 cases. I did write this down, so let me just check my numbers. We had 1,300 cases of congenital syphilis in 2018 and 3,700 cases of congenital syphilis in 2022. So clearly we have a significant problem. Is this impacting you on the prevention side? Probably not. This is really where we need to make sure all of our obstetric providers, OBGYNs and family medicine providers are doing everything that they can to follow the guidelines and make sure that women are tested and treated. Our maternal syphilis rate has skyrocketed. 10 years ago, 5 years ago, we were thinking syphilis is almost exclusively in the MSM population, the population of men who have sex with men, but it is now affecting everybody. It's still disproportionately impacting the population of MSM, but we're seeing so many more cases of maternal syphilis. And congenital syphilis has gone up 10 times in the last 10 years, excuse me. And of course, the impact of congenital syphilis is extraordinary. So anemia, thrombocytes, all sorts of hematologic impact. I mean, it's just, that would be a whole nother lecture. But it's just unbelievably important. And you guys, if you haven't started seeing some cases, are likely to start seeing some cases. The second thing, and then I want to have a little bit of time to tell you what we're doing, is hepatitis C. So I just want to share with you that hepatitis C, we are turning the corner on hepatitis C because it is 100% curable now, and we're starting to see lower rates, but we still are not reaching enough people. And what that means is that we're still seeing perinatal infection. And what I wanted to make sure that you guys are aware of is that in November 2023, the guidelines changed and CDC recommends hepatitis C testing for any child who has been perinatally exposed to hepatitis C. So I don't want to get into the details because I just want to make sure that I'm increasing your awareness that there are these guidelines, they are available to you. So here's the algorithm for NAT testing in children aged 2 to 6 months. Obviously, the most important thing is making sure that you have a history of the mom's hepatitis C status at delivery. And then for any child above the age of 18 who has not been previously tested. So these slides are available. Do you guys, if you can make the slides available, I just want to make sure that you are aware of these new guidelines because it does impact the care of the children that you're seeing. And then the last thing I wanted to make sure that you're aware of, and then we'll open it up for more discussion after I go through what the health department does, is that the Red Book finally has come out that you can do an interferon gamma release assay in children under the age of 2 if you are suspecting latent TB, if they're coming from another place. And it used to just be TSTs under the age of 2. So now you can do a IGRA or a TST.
So it's equivalent, because they were saying for the longest while that it was not an accurate test under the age of 5, and then they went down to 2.
Yeah, it wasn't that it wasn't accurate, it was that they didn't have enough data. It gets back to research. So they just didn't have enough data to show that it was a valid test. And so we at the health department were like, yes, finally. Because it's just, if you're drawing blood anyway, getting the IGRA is a lot easier than making a child go through a TST. So this was out in the literature at the study level. We started doing it a little while ago but officially Red Book has adopted it. So I was very happy about that. So I just wanted to make sure that you were aware of these new guidelines and hopefully will improve care. So just partnering to improve health, we have an annual report which we publish every year. I still have a couple minutes.
Question in the chat.
Oh, okay. Do you want me to take the question in the chat first?
Sure, I'll just give it to you real quick.
Yeah.
Can you touch on pertussis outbreaks as well? I'm getting several families who are saying they have a confirmed exposure.
Yeah, so, that's really important, and I mentioned it briefly. We are seeing pertussis. We've actually seen a couple of cases of chickenpox lately. Pertussis is happening across the state. It is definitely happening in Southwest Virginia. One of the frustrations that we have, and I know that this is difficult, is that it is a tough diagnosis, right? Like, by definition, you have to, unless there's a known exposure, the child has to have a really violent cough or a prolonged cough before you're going to consider testing it. But if you could lower your threshold and just knowing that we have pertussis outbreaks, as a general rule, once pertussis gets into a community, it just kind of percolates there for a little while. So I expect that we're going to see higher levels of pertussis for the next year. That's really sort of being a Debbie Downer, but just based on previous experience. So just have a lower threshold for testing and certainly for treatment. We did have a situation of a confirmed case of pertussis a couple of weeks ago where the child had been seen, I think, in like 4 different EDs or urgent cares and their PCP, and pertussis was never considered until like the 5th admission or the 5th evaluation. And so if you have a child with a persistent cough, just test. Yeah, I know, that's easy. So low value care, right? Like, just test, but just consider it in your differential. Put it higher in your differential today than you would have a year ago. Does that make sense? I don't know if that answers the question.
Can I ask maybe a little bit of an ignorant question? And this is maybe for Dr. Morrow or the other PCPs. What is our best testing modality? Whenever I did training, it was part of our BioFire that we got a pertussis PCR back in an hour, which is really nice.
Nice.
It was amazing.
Look at my face. I'm like, oh.
Is it a PCR or is it culture?
We do PCR, but it does not
Around
go out
time
in an hour.
Yeah.
I'm pretty sure about that. Yeah.
It's 3 to 4 weeks for the PCR. Yeah, it can be used like 3 to 4 weeks after the onset of the cough.
No.
But the
What's the
testing
turnaround?
no, it's not weeks, but it's not the same day. I've never gotten anything back the same day. It's a
That's
couple
a
of
send
days.
out then. Cool.
We did
Thank
have
you.
a case recently, but it was an older child.
Culture is 2 weeks.
We have, not in our district, but one of the other districts I happen to be covering, they have several cases in college-age students right now. So the health department, we do a lot of things, but focusing on the things that we do for the pediatric population, home visitation. When we talk about infant mortality, extreme prematurity, congenital anomalies, one of the things that we, obviously home visitation is not going to help with congenital anomalies, but enrolling your families, your at-risk families in in home visitation services can be really impactful. CHIP of Roanoke Valley is the most comprehensive home visitation program that we have here. We also have Healthy Families, and we, the health department, provide baby care as sort of the safety net, but CHIP of Roanoke Valley provides the most comprehensive home visitation services. Early intervention, we administer the early intervention program here, and then we do rabies and lead post-exposure case management. We do 100% case management if you have a child who's identified as having an elevated lead level. But with respect to the things we've talked about today, we have a car seat program. So it's health promotion. We provide health education around car seat safety and then give the families who qualify a car seat. And you can see our numbers have dramatically increased in the last few years. So last year, in 2023, we gave over 465 car seats away to families in need. In addition, unsafe sleep environments are a leading cause of preventable death in children under the age of 1, and we know that a lot of SIDS deaths are incorrectly classified, a lot of unsafe sleep environment deaths are classified as SIDS deaths, and so we feel very strongly about the importance of every family having a safe sleep environment. We provide education and not only a pack and play, but sleep sacks for children to decrease the risk of death associated with unsafe sleep environments. We also provide the Women's, Infants, Children program, which improves the health of the children that we serve. We talked about poisonings as being a leading cause of accidental deaths in adolescents. We have a very strong substance use disorder program, which we work with a lot of community partners, and then reportable diseases. reportable diseases. So excluding COVID, we investigated about 700 reports of diseases last year. Pertussis was less than 5, so we have to suppress it if it's less than 5. But we are seeing a lot of other diseases. And you can see, we talked about hepatitis C. So last year, we had 262 cases of hepatitis C reported to us, chronic hepatitis C reported to us. And then I just wanted to share our congenital syphilis data, or so this is the state's congenital syphilis data, and you can see Southwest region. We haven't had too many. 2022 looks like it was an aberrant year, but our syphilis data for all cases was almost 100 cases last year, where we used to have maybe 10, 15 cases. So that is it. I think I answered quite a few questions while we're going. Are there any other questions online?
Not right now. I
Definitely. Perfect.
And besides home investigations for lead poisoning, what else does the health department do? Is there still a program where they can go into the homes? At one point, there was like a grant funded and help the families actually.
So we don't do that, but what we will do is we will work with Lead Safe Virginia. And so if there's a child who's identified as having an elevated lead level, depending on the extent of the elevation, we will go to the home and we'll do diagnostic testing of lead in the home. Depending on what we find, we'll refer that family to Lead Safe Virginia, and they have the funds to help the families mitigate their home to decrease the risk. Yes?
So, I can't remember how many months back, I got a message or an email from the Virginia Department of Health discussing the new syphilis testing guidelines for pregnancy, that it's supposed to be first, third, and at delivery.
And at delivery.
Yes. What are you seeing the uptake of that? Is it, yeah,
Yes, so unfortunately, speaking of data, we don't have a mechanism to track that. So that's really up to the healthcare delivery system to develop quality metrics around that. But as the health department, there's no way for us to track those data. Sorry.
yeah, it's just, it seemed to be that previously we were really under-recognizing, not only just in this epidemic, but even under-recognizing at-risk individuals. And so I was really excited when I saw that recommendation come out.
Yeah.
Because it seemed necessary.
And there is some speculation that because, with everything, right, the more you pay attention to it, the more you find it, which is great. So there is some speculation that some of our numbers are higher, like our maternal syphilis numbers are higher because we've been really vocal about making sure that people know what the guidelines are. But we just don't have a good way. Again, that's the healthcare delivery system should have an excellent way of testing that or of evaluating that, but we don't have a mechanism to evaluate the impact. Yeah. Any other questions? All right. Well, thank you so much.